Or there could be a tumor, for example, that's spewing them out with disregard to feedback. Any of those type of things can occur. So there's numerous possible disorders in the endocrine system. I've shown you this picture. Again, I really want you to focus on the fact that the hypothalamus is just sitting right above here. Here's the stalk connecting the hypothalamus to the anterior and posterior pituitary, and then here are those hormones that come off of the anterior pituitary, and then those are the hormones off the posterior. And again, all of these hormones right here are shown on this one piece of paper. That's why when I was studying this, I wanted to see it all on one piece of paper and kind of see all the flows, the sequences all the way down the line from the hypothalamus to the anterior pituitary to the target gland to the target tissue. Very, very important slide there. And this just kind of summarizes, these are the main hormones coming off the hypothalamus, TRH. And notice that all of these target the anterior pituitary, because that's exactly where they're going to go. They're going to go from the hypothalamus up here, and they're going to come down and hit the anterior pituitary, and then all of these will ultimately be released. So hopefully at this point in time, you're starting to breathe a sigh of relief that, yeah, I can get this. And all of these hormones are shown again on this one piece of paper. It's why I really kind of like this layout, because it shows you TRH is right there, the GnRH is right there, the GHRH is right there, and then you can just see what happens when it hits the anterior pituitary, what downstream hormones are released, and then what their targets. Okay. CRH, again, the CRH pathway is right here. The prolactin pathway, the inhibiting factor, dopamine, is right over here, and the releasing factor, PRF or PRH. And sometimes these are called factors. Sometimes you'll see it called prolactin releasing factor. Sometimes you'll see it really called prolactin releasing hormone. It's the same thing, okay? Again, you're just seeing another picture there. Anterior pituitary, again. And by this time, ladies and gentlemen, you're probably saying, I got this. Okay, so, and remember, if you get a little bit confused somewhere down the road, just come back. Just back the slides up a couple of slides and say, okay, now I got that, because all of these slides will build on one another. That's one of the beautiful things about the study of healthcare. Your biology, your anatomy will build on biology, physiology will build on anatomy, and pathophysiology kind of builds on all of it. Just again, showing you the anterior pituitary, and here's all those hormones, GH, ACTH, TSH, and of course here they are again. There's your GH, there's your TSH, there's your ACTH, and so on and so forth. There's your FSH and your LH. And you can just see the target. These are the target, and some of the targets. For example, the thyroid has many targets beyond the thyroid. It has almost every cell in the body. Cortisol, for example, the ACTH will hit the adrenal cortex and it will release cortisol, and then cortisol has many effects throughout the body, and on and on and on. Well, that's what we're taking a look at today. Now, the posterior pituitary sometimes is kind of forgotten, if you will. Maybe it's not as doesn't have as much activity, but it's extremely important. The two main hormones coming off the posterior pituitary are ADH and oxytocin. And again, they're shown right on this chart. There they are, ADH and oxytocin. They're coming off the posterior pituitary. They're actually manufactured up in the hypothalamus, and they're just stored down here. And ADH, and we're going to talk a lot about this in just a moment, but basically what it does, it controls plasma osmolarity. Okay, and so I want you to think about it. What is diuresis? Diuresis is urine. Okay, so if you're urinating or if you're diuresing, you're going to be losing water, and you're going to be becoming dry, if you will, and you're going to leave behind kind of concentrated solutes. Okay. On the other hand, if you're retaining water, those solutes are going to be watered down. Okay. So that's all osmolarity is. When we have, and let's take the classic one, which is sodium. Okay, sodium, the normal range of sodium, you will, if you venture out of that normal range, okay, and you have too much sodium, okay, which you would be hypernatremic, okay, then we can, the body will detect that it will detect that high level of osmolarity of the blood, and it'll say we need to water that down. And the way we'll do it is we will retain water so that we will secrete ADH, and that's anti-diuresis. It will stop the diuresis. And the way it does that, it goes to the tubules of the nephron in the kidney, and it basically says reabsorb water. Don't urinate the water out, reabsorb it. And then when it does that, it will naturally water down the sodium and all of the other solutes in the bloodstream. Okay. Now, oxytocin will give uterine contractions. That's one of the most important effects that it has. And so if in the hospital the healthcare team wants the patient not to have contractions, they will give a medication that will be an antagonist to oxytocin to calm down and delay those contractions. Okay, this just shows you alterations of the hypothalamic system. The most common cause of dysfunction at the hypothalamus level is an interruption in the stalk. So here's the hypothalamus up here, and then here's the stalk between the hypothalamus and the pituitary. Right in the middle, if you have a dysfunction of the stalk, none of these hormones are going to be able to get through. And if these hormones don't come through, the GnRH, the TRH, the CRH, etc., then the anterior pituitary is going to be low on all of these. Okay? And this may show up, and you may think, hey, the patient has a problem with their pituitary. But the problem, in fact, might be with the hypothalamus. Okay, now let's look at one of the first diseases we want to look at, which is SIADH. Bear with me 1 second here. And so SIDH is going to be the first one, and this is just syndrome of inappropriate, and that's just kind of what it sounds like. You have an inappropriate level. It's too high, too much ADH. Okay, but just stop and think about it. That means that you're going to have too much water, and the solutes in the bloodstream are going to be watered down. So, for example, the normal range of sodium is 135 to 145. If you water that down, it's going to be below 135, and you're going to be hyponatremic. And that would be one of the signs of SIADH. And you can see patients that get down into 120, 119, 118, 117. And when that happens, they have such a low concentration of sodium that their neural system doesn't work effectively. And one of the things you will see is a change in cognition, a change in behavior. Patients will be very confused. They will be acting bizarrely because sodium is and other electrolytes are so important to the function of the nervous system. Okay. Now, what might cause this? Well, central nervous system disorder as a result of surgery. Certain medications can throw us into a hyper ADH condition, or if you have a tumor. If there was a tumor in the posterior pituitary, it would just be spewing out ADH without any regulation. Okay. And what is the pathophysiology here? What goes wrong? The kidneys just absorb too much free water. They retain the water, and this causes a dilution of the solutes in the vascular system. And you will get a fall in the serum will be hypotonic, and especially a decrease in sodium concentration. And this is what we call dilutional hyponatremia. You actually have enough sodium, but it's just you have too much water, so the concentration is low. And if we can turn off the ADH, then the body should be able to adjust and return to an isotonic state. Okay. And one of the interesting things when you look at these endocrine diseases, there will be a hypo and a hyper. Now, the opposite of SIDH is DI, or diabetes insipidus. We'll talk about that in a moment. But always keep in mind that when you're looking at the normal function of these hormones, you have to ask, okay, what happens if they're too high? What happens if they're too low? If they're too high, you have a hyper disorder. They're too low, you have a hypo disorder. And the effects tend to be just mirrors of one another. Okay, now, what are some of the manifestations of SIDH? Okay, the patient will be unusually thirsty, especially if we have what's called psychogenic SIDH. There are certain patients that they'll drink out of a fish bowl. You know, they just crave water so much. And of course, there's so much, they're taking in so much fluid that they're cramping, vomiting. They will have dyspnea on exertion. That's the trouble breathing, because the fluid can actually accumulate in the pulmonary area. They'll be tired. Seizures because you need to have a normal level of sodium and normal level of potassium in order to maintain the neural system. And when these electrolytes get out of balance, the ability of the nervous system to regulate itself is lost. So you have either not enough action potentials, or you have poorly controlled action potentials. Changes in sensation, neurological deficits of all sorts. If this is persistent, you can actually have irreversible damage. Now, if it is reversible, as soon as you correct the hypo condition, it will resolve. Okay, now how do we diagnose this? The blood or serum, the blood is has hypoosmolarity, and especially it has low sodium. The urine will be hyper concentrated, and this is very important to keep in mind. In SIDH, we are retaining water. We're not urinating it. So what urine is produced is highly concentrated. So the blood is going to be hypotonic and the urine will be hypertonic. Just the opposite. Now, in diabetes insipidus, where we're urinating all the time, it's going to be just the opposite. The urine is going to be very watered down because it's unusual amount of urination. So the urine will be hypotonic and the blood will be highly concentrated or hypertonic. We'll get to that in a moment. But the adrenal and thyroid function will be normal. Okay, and there won't be any other condition that might have altered the volume. Like say they had a GI condition and they had a lot of nausea and vomiting, so they were losing sodium that way. We would rule those out, and so that's how you kind of establish a diagnosis of SIADH. Now, just the opposite of SIADH is diabetes insipidus, and this is too little ADH. And the two classic signs of this are polyuria and polydipsia, or unquenchable thirst. And the reason of that, of course, is they're just urinating out the water, so they have a constant desire for thirst. And then also they're constantly urinating. Now, in diabetes mellitus, remember, you have that third polyphagia, they're constantly hungry because the glucose is not getting into the cells. So even though the patient is eating, they're not getting enough glucose, and so they're hungry all the time. That's diabetes mellitus. This is diabetes insipidus. Now, there's a couple possible causes of this. One is neurogenic or central, which means that they don't have enough ADH. Okay, and you can have, what could cause that? Well, you could have a lesion on the stalk, which limits the flow of ADH, or it could be nephrogenic, because remember, ADH targets the nephron, it targets the kidney. And if the kidney does not respond to ADH for whatever reason, even the ADH itself could be normal, but if the kidney is dysfunctional, it's not going to respond to the ADH. And it's just going to continue to let the water come on out, flow out in the urine. Okay, now, The next disease we want to look at is growth hormone disease, and there's basically two conditions. One is gigantism and one is acromegaly. And gigantism occurs in children and adolescents before the plate of the long bones has fused. So you know that the long bones all have a growth plate. We'll just kind of illustrate that in a crude manner here. We'll use the femur, for example, the large bone attached to the hip joint. So here's a femur, and there'll be a little growth area. The bones don't grow all uniformly. They grow in kind of a growth area called the physes, and during childhood and adolescence, they will continue to grow. But once, and if you have too much growth hormone, they're going to grow in a giant way. But if once they have reached adulthood and this is fused, then they're going to start growing widthwise or thickness, and that's called acromegaly. Okay? They're two very, very important diseases to consider there. Okay. And you'll notice the change here in this patient here. You can see the change during her adolescence and young adulthood, but as she became moved into adulthood, of course, the features became thicker and thicker. These just show you some of the manifestations of acromegaly, and you can read all through those, and just the whole. I think you'll get the idea that just in general, the body just has too much growth stimulus, and it becomes thickened in adulthood. Now, the thyroid. The thyroid, of course, is right in sort of the central neck area, and it sits just kind of wraps around the inferior larynx area. And on the posterior side of the thyroid, you'll notice these thyroid gland areas, which are just little regions of a little bit different tissue, but very, very important different function of tissue. Okay, so we're going to go take a look at the thyroid at this point. These are the follicle cells. These are the cells that secrete TH, or thyroid hormone. Now, thyroid hormones, these are just some of the effects of thyroid hormone. Now, it helps normal growth, and if a baby is born hypothyroid or without a thyroid, this can be one of the #1 causes of poor sexual development, poor development in general, but sexual development and mental development especially. It's one of the #1 causes of retardation if the child is not properly diagnosed. Okay, now, what are the effects? The normal effects of thyroid hormone will be to stimulate growth and development. It will affect cell metabolism. You can just underline that. It's critical. If cells are stimulated by thyroid hormone, the metabolism will increase, and they will need more calories to support all of that additional metabolism. So they'll need more glucose, more oxygen, and so the heart will beat faster, the lungs will breathe a little deeper, etc. The patient will be hungry, and yet they'll still be losing weight because the cells are burning off that extra glucose. Because increased thyroid hormone will raise the metabolism, it will also increase the production of heat and also the consumption of oxygen. It will block insulin. And one of the reasons for this is that if thyroid hormone is secreted, thyroid hormone is going to increase the metabolism. Okay, and so for cells to have a lot of metabolism, primarily in their mitochondria, they're going to need glucose. Okay, so insulin takes glucose out of the blood. Well, thyroid hormone wants glucose in the blood, so it's going to be an antagonist against insulin. Okay, it also will give you muscle tone and vigor. If a little more thyroid hormone is going to allow the muscles to have a little more tone, a little more strength and activity, and also the heart will beat a little stronger and a little harder and with more output in the presence of increased thyroid hormone. Thyroid hormone also helps the GI tract continue to digest, and the reason for that is it wants the glucose. It wants the digestion to occur in order to provide those nutrients to keep all the metabolism going. So think to yourself, if you have too much thyroid hormone, are you going to have diarrhea or are you going to have constipation? It will be diarrhea because the GI tract will be so activated. If the patient has low thyroid hormone, then they're going to be prone to constipation. So you can start to see that you can make your diagnosis based on those symptoms. And we'll talk much more about those in just a moment here. Okay, so here is hyperthyroid, which is too much thyroid hormone. And this can most commonly be caused by Graves' disease, but can also be caused by what we call multinodal goiter, which are little nodes, little toxic hypersecreting nodes of the goiter. Okay, or a single adenoma, a single tumor there. Now, thyroid toxicosis. This is a catch-all term that refers to all of the symptoms you will see if a patient has hyperthyroid. And remember, I showed you in the book the picture of that lady that has the one side of her is hypothyroid and the other side is hyperthyroid. Well, the thyroid toxic signs and symptoms are going to be from the hyperthyroid side. Now, remember, I also showed you in the book that you can have primary, secondary, or tertiary hyperthyroidism. Okay, now if it's primary, that means the disease is at the level of the thyroid gland and you have elevated T4 and T3, it keeps spewing it out, and you have the negative feedback to the TSH, but it doesn't matter because the thyroid is producing this hormone autonomously, without any stimulus. And let's just revisit that real quick. It's an important chart. Here it is. Here is your primary, which is a disorder of the thyroid itself, or your secondary, which is a disorder of pituitary, or you can also have a disorder which I call tertiary disorder of the hypothalamus. And you can see what will happen to the levels of TRH, TSH, and TSH and TH in each one of these cases. And you very well could see that on the test very easily. And again, this is a really nice little illustration of all the signs and symptoms that you will see in hyperthyroid versus hypothyroid. How the heart will be affected. It'll be bradycardic if it's low thyroid. It'll be tachycardic if it's high thyroid. If it's hyper, you're going to be having a lot of metabolism, so you're going to be losing weight. If it's hypo, you're going to be gaining weight. If it's hyper, you're going to have diarrhea. If it's hypo, you're going to have constipation, and on down the line. So I think you can start to see those distinctions. And again, the hyper disease is just going to be a mirror image of the hypo disease, just kind of in reverse. Okay, secondary hyperthyroidism, which, and this is a really nice little illustration here. This shows you the toxic multinodal goiter, the adenoma, and it also shows you in Graves' disease. In Graves' disease, what happens is that the body kind of attacks itself, and it sends antibodies, which is the IgG, the immunoglobulin G or gamma, and this will actually go to these antibodies will go to TSH receptors and tell the thyroid, hey, produce more T4 and T3, which of course is not what we want the body to do. We want it to respond to the TSH, not to antibodies attacking the body itself. But that's what happens in Graves' disease. Or you could have a nodular goiter. And one of the cases that we kind of sometimes see this is in pregnancy, because the patient, when she is pregnant, is going to use the thyroid hormone to kind of support all of the metabolism that's going on. And the thyroid can kind of get a little bit overactive during pregnancy, and then after the delivery, then you're still left with some nodules there. Or you could actually have a primary cancer of the, or either benign or malignant of the thyroid. Okay. Now, and something else that can cause hyperthyroidism is giving too much thyroid pills. That also can cause a lot of, if you give too much, you can actually plunge the patient into a hyper state. Okay, now what are some of the manifestations? Now, you go back to that picture that I just showed you of the lady. At the endocrine level, they'll have an enlarged goiter, and that's an enlarged thyroid gland. They will have decreased TSH, because remember, the negative feedback is going to say, hey, I've got so much hyper TH that we can turn off the TSH now. The reproductive system will be affected. The neurological system, they'll be very restless, hyper reflexive. They're going to have an increase in cardiac output. The heart will be beating faster. Pulmonary, they may have trouble breathing. GI, the weight loss, because, and this is a very important question you oftentimes will see on the test. If a patient comes in and they're complaining of feeling hot and they're losing weight, and yet they're eating all the time, what kind of disorder might that be? And your answer would be hyperthyroid. The skin, very importantly, you'll see sweating, flushing, warm skin, and fine, soft hair. Please underline that. For hypothyroid, on the other hand, you'll find dry, brittle hair. And also, very importantly, heat intolerance. This oftentimes is a dead giveaway. If you go into a patient's room and it's the middle of winter and they have the air conditioner on because they're hot, you can be pretty sure that's a sign that they just can't stand any. They want to be cold all the time because their metabolism of the body is elevated, and so they're producing all that heat. On the other hand, on the hypo side, if they're cold intolerant, and this is the patient you go in the middle of summer and they have the heater on, then you can see that, again, they're not getting that heat produced by the metabolism. Now, very importantly, you might get something called myxedema in the case of Graves' disease in the pretibial area, in the leg. And the exophthalmos, which is the bulging eyes. Again, very, very key giveaway in Graves' disease. Okay, goiter, there's a picture of your goiter. Graves' disease is the #1 cause of hyperthyroidism, more prominent in ladies. We don't really know what the cause of it is. We don't really know what triggers it, but we do know that what it is that the body basically attacks itself, and it sends antibodies to stimulate the release of TH from the thyroid, and you can read about that. That's Graves' disease. Manifestations, here's your bulging eyes, your exophthalmos, okay, and you may get, if it's bad enough, there is a possibility of something called a thyroid storm. And a thyroid storm, ladies and gentlemen, is just kind of where a hyperthyroidism meets stress. Or you might say it's where excess thyroid hormone meets epinephrine. When those two come together, you can have kind of a self-feeding, real medical emergency. Okay, and you can read about that: tachycardic, hypertensive, very, very hot. The heart will start to fail. They'll be very agitated and delirious. So this is one condition that can result in the unmanaged patient. Now, hypothyroid, let's look at just the opposite condition. And that, if you go to your picture in the McCann's book, that's going to be on the left side. And this is for patients that don't have enough thyroid hormone. Now, if the problem is primary, if the problem is at the level of the thyroid itself, the thyroid is just not going to be producing thyroid hormone, even though there's plenty of TSH and TRH. The hypothalamus and the pituitary are doing what they need to do because they have detected that there is low TH. But even though these things are being stimulated, the thyroid does not respond. So that's really the disease there. Secondary would be a problem in the central area, up in the brain, and this could be a problem with the pituitary and or with the hypothalamus, and you can read about that. But the secondary is the pituitary's failure. The pituitary does not secrete TSH. Okay? And so you can read through all of these conditions, and you very well could see a question on the test in secondary hypothyroidism. What would you expect the labs to show? Well, you're hypothyroid, so your TH is going to be low, period. Because it's secondary, then you have to go up to the TSH. That's the next one. That's the second one up. TSH, it's definitely going to be low. Okay, so then it's just a question if the hypothalamus is involved or not. If the hypothalamus is not involved, then the TRH will be normal, the TSH will be low, and the TH will be low. But if the problem is at the level of the hypothalamus, the TRH, the TSH, and the TH, all three of them will be low on your labs. So you easily see that in the question. Now, on the hypothyroidism, here's your signs and symptoms. The metabolism is going to be slowed down. So because in the presence of slow metabolism, the patient's going to gain weight if they eat the same amount of food. If I eat 2,000 calories a day and my metabolism goes down, I'm going to gain weight because I'm not going to be burning off those calories. I'm going to be cold intolerant because I'm not producing the body heat, coarse, brittle, dry hair, loss of lateral eyebrows, the tongue will get enlarged, the bradycardia, the heart will slow down, and then you'll start to get the changes in the connective tissue in the dermis. You start to get this what we call doughy edema. It's kind of and now Hashimoto's disease is one of the main causes of hypothyroid, the #1 cause in the United States, and it's basically an inflammation and destruction of the thyroid. Okay, oftentimes it runs in families, and one of the results of it, if this what we call this doughy edema, or it's oftentimes called non-pitting edema. It's a very tough edema. It's not like a watery edema. And again, it's a complication of severe untreated hypothyroidism. It can result in central nervous system depression and coma, and it can produce all of these other negative effects. Now, just imagine that if you have this edema building up around your heart, what problems that could produce just in the heart itself. So this is a really life-threatening condition if it's not addressed. Now, what happens if the baby is born with low hypothyroidism? They will be risk of growth retardation. They won't properly absorb nutrients. They'll be constipated all the time, and at a risk of both the retardation of their growth and of their mental capacity. So we need to have early thyroid replacement, and that's why you need to screen the newborns if any of these symptoms are suspected. Thyroid cancer of the thyroid is relatively low, but you can read about the signs and symptoms here. Again, first things we might notice is kind of a nodule. You might palpate a nodule. The patient may report that they're having difficulty swallowing, or they have a change in their voice or their breathing patterns because the thyroid just sits right around the airway there. Okay, now let's check what we've studied here about the thyroid. Which of the following is true regarding thyroid hormone and TSH release? Okay, is this true? TSH secretion is controlled by positive feedback. So the more TH you get, that will stimulate more TSH. Well, that's incorrect. Okay, the more it's stimulated by negative feedback. Okay, as TH rises, TSH will fall.